You're listening to Aging Uncensored.
And so we emerged from World War II in this highly favored position in terms of our healthcare system. Our infrastructure is completely intact.
Right.
You know, outside of Pearl Harbor and the Aleutians,
Right.
and one bomb that went off in the woods of California,
Yeah.
nothing happened,
Yeah.
you know, in the United States.
Yeah.
We have a huge move forward in the terms of the knowledge base about how to take care of the ill, and we have antibiotics. Now, for the most part, antibiotics at this period are IV.
Oh, I don't think I realized that.
So they have to be administered in the hospital. So we start to shift the site of care and how we think about care away from the home to the hospital. And the hospital moves from being this entity which has this very narrow thing to the place where the miracle happens, because everybody in society, you know, during the mid to late 40s sees someone they know they would have watched die at home, go into the hospital and walk out.
Yeah, that's still deeply rooted into our culture today,
Yeah.
I would say.
And that's where it comes from.
Yeah.
And so the hospital, you know, we develop culturally this idea of American exceptionalism in medicine. Because in the 1940s and the 1950s, it's absolutely true. Nobody else can touch us. You know, most of the rest of the developed to the Western world, you know, their infrastructure's been bombed flat and they have to rebuild everything. And so they must do so in a very cooperative way. So they develop socialized medical systems as part of their rebuilding process. We didn't have to do that here. And what we fall into a historical accident. And that historical accident is that in the late 1940s, the economy is basically based around heavy industry and factories and steel mills and coal mines and all of that kind of stuff. The troops are coming back from World War II, and we are gearing up to create the consumer goods that the world has been starved of for, at this point, 16 years, since 1929 and the Depression started. And we're not only going to create them for the U.S., we're going to create them for the world, you know, while they rebuild their capacities and their factories, and most of which have been bombed.
Yeah.
So everybody is hiring, and there are jobs to go around, and there are still laws on the books left over from the Depression that on wage and price controls. So if you are running a steel company and you're trying to hire, you know, another 1,000 people, and there's another one down the street trying to hire 1,000 people, you can't offer them a higher wage.
Oh.
What can you offer instead? Well,
Okay.
heavy industry in the early 1940s was ruled by women because the men were overseas. And the rulers of heavy industry came to realize that as women were manning the factories, that if the women, or more importantly, the women's children, became ill, they missed shifts. And so in order to, you know, maximize their productivity, it behooved them to actually care about the health of their workers and their families.
Yep.
And so it particularly started in the shipyards of the Pacific, and kind of the powerhouse leader was Charles Kaiser of Kaiser Aluminum, and you know, we still have a Kaiser health system.
We do.
And you know, that's where it all comes from.
Huh.
And here we have this idea of industry should have this responsibility to take care of its workers and its workers' health. And if we can't offer them more in terms of money, we can offer them a benefits package.
Yep.
And part of that can be that we promise that we will take care of the health of that person and their spouse and their children.
Also still deeply rooted into today's society.
So that's where employment-based health insurance comes from. By 1947, you know, the titans of industry went to D.C., had the tax code rewritten so that it became beneficial to them to actually be able to offer this as part of the benefits package. Now, we're in the late 1940s, and we've developed this very weird employment-based system that takes root nowhere else. And there are going to be populations that are left out.
Yep.
The post-employed being a major one.
Yep.
Is the retirees. So in the late 1940s, and actually this had been kicked around as part of the New Deal in the 1930s. And FDR, I kept meaning to come back to it, but he, got kind of sidetracked with World War II. And, but, that we really should have some sort of a national health insurance program. And,
Yeah.
And so he handed that idea off to Harry Truman. And Harry Truman, under his administration in the late 1940s, early 1950s, actually kind of broke the back on kind of figuring out what Medicare would be, health insurance for the post-employed or for the people who could not be employed because of, their disabilities of whatever type. So he was kind of starting to push that along, and it ran into Joseph McCarthy. Socialized medicine, communist red. Needless to say, it did not get very far in Congress after all of that happened.
Yeah.
And it was basically tabled through the 1950s. And we don't get to the point where it can become law until we get to the Great Society programs in the early 1960s, which is why it just didn't exist there for quite some time. And what was happening in the 1950s is that people were aging, they aged out of, employment-based insurance. They had nothing. They were, expending, what they did have on medical care. The hospitals are still owned by not-for-profit entities with a mission of social good. And everybody knows that's where the miracle happens. So if you're 72 in 1956 and you develop pneumonia, what are you going to do?
You go to the hospital.
You go to the hospital, and they've got a mission to take care of me.
That's right.
And who is paying the bill?
Yeah.
Well, basically nobody. And so by about 1960, the hospitals were, going to Congress saying, look, we aren't going to have any hospitals another 10 years if you don't do something. And that was the impetus behind getting Medicare and Medicaid put into place. There was the hospital lobby more than anything else. And that's another reason why the hospital remains the centerpiece of how our health system works.
Yeah.
It's the 4 days a year that the average senior spends in the hospital, not the 361 days that they don't.
Yeah. Yeah.
So the hospitals are in the early 1960s are pushing and pushing and pushing to get a payment mechanism, which we eventually call Medicare, into place. And you don't get anything through Congress without there being a huge fight, particularly social services. So there was an equally powerful lobby pushing against the adoption of Medicare and Medicaid. And it was the AMA. It was the doctors. Because basically the doctors went back to first principles, which is medicine is not really completely explainable. There's something mystic about that bond that happens between a healer and the person who comes to be healed that still kind of comes out of the religious context in that. And the only people that should be making decisions about what is right, within that, are the people in that bond. But if you insert federal dollars, you are inserting a third decision maker. And they were quite right, of course.
Absolutely, they're right. Yes, that's.
But
yes.
and they went on a huge anti-Medicare Medicaid campaign, and they had to have a celebrity spokesperson because we're now in the 1960s. This is the Mad Men era, and we now are working with advertising and PR as a science. So they hire this out-of-work B-movie actor to be the celebrity spokesperson of fight against Medicare. His name was Ronald Reagan. This is where his political career starts.
Oh wow! Okay.
is as the celebrity spokesperson for the AMA, and you can still find like his speeches and that on YouTube if you have any interest.
Yeah.
And he found that he liked politics so much, that he kind of moved on and eventually becomes governor of California, of course, 15 years or so after that, president.
Yeah.
So that is where he comes from. Now, the hospitals win. Medicare does become law.
Right.
And Medicare becomes law alongside a sister program called Medicaid.
Mm-hmm.
Now, they're somewhat different.
Mm-hmm.
Medicare is strictly a federal program,
Mm-hmm.
and all of the dollars within it are federal.
Mm-hmm.
And it is funded through combination of taxes and Medicare withholdings from paychecks and various other mechanisms. And basically, if you have paid into Social Security and Medicare withholdings for long enough, you will get it.
Yep.
And the requirement is that you have to pay in for a minimum of 40 quarters or 10 years.
Mm-hmm.
And as long as you've had those withholdings, and even your little summer job when you were 15
It
counts.
counts as a quarter.
as long as you've got 40 quarters, you will qualify for your Social Security check and for your Medicare A, which is your hospital insurance. Medicaid, on the other hand, is not strictly a federal program. Because Medicare is a federal program, it's the same everywhere you go in the country.
Right.
It's the same in Florida as it is in Alaska. It doesn't change.
Right.
Medicaid is because it is a combination of federal and state dollars. Every state gets to write the rules for Medicaid the way they want.
That's right. And they do not transfer. Just because you have Medicaid in Alabama doesn't mean you have it in Mississippi.
Yeah, and it is
It's
by
not what that
state.
means.
And most states require you to be resident for a minimum of a year before you can even apply for Medicaid in that state.
Yep.
Medicaid will pay for things that Medicare does not. Medicare is designed solely to pay for that access to acute care. Medicaid will pay as a payor of last resort for people who have no other assets for things like custodial chronic care. Medicare don't pay for the nursing home other than in very limited circumstances to recover from something.
Yeah, but not for long-term care.
Medicare does not pay for any kind of long-term care, but Medicaid will. But Medicaid will only do it if your other assets have been exhausted.
That's right. It's very nuanced and complex, and people hire attorneys to
Absolutely.
get it sometimes.
Particularly if there are assets.
Yep.
And Medicaid in most states is allowed to look back through your finances for 5 or so years. So, to make sure you didn't move all your money elsewhere just to qualify for Medicaid.
Yep.
So, if you have assets, a financial planner and an attorney is a very good idea to have as you age because of how complicated this can all get. Medicare, when it rolled off the assembly line in 1965, Medicare A was the hospital piece. And that hospital piece, basically, there is an annual deductible. And then after that, it pays for hospitalization as you require it. Now, when the doctors realized they were going to lose the war, they basically said, okay, me too. So together with Medicare A came Medicare B. And Medicare B, unlike Medicare A, does not fall into place automatically. You must elect it if you are eligible. And you are required to pay a monthly premium for it. And now this premium is dollars that are taken off of your Social Security benefit, so it's money you just never see.
Yeah.
So, and most people elect it because they realize it's a pretty good idea.
Yeah.
There are places in society where people do not elect Medicare B, particularly people who have been long-term users of the VA.
Yeah.
Because
Sure.
the VA
Get their
is a
medical
very
care
separate
there.
system.
Right.
And does not require you to have Medicare B to have outpatient treatment if you are qualified for, health benefits through the VA.
Yeah.
And so there are any number of people who are veterans who may not have B. They'd rather have that extra $150 a month in their Social Security check.
Yeah, fair enough.
Medicare B pays for outpatient treatment and things like the doctor's office, the lab, the x-ray, things like that. Medicare B was not ever meant to be a full payment. It was what is known as an 80-20 indemnity program, meaning that Medicare B is responsible for 80% of your medical bill, and you are responsible for 20% of your medical bill.
Still can be a significant amount.
Yeah. Well, in 1965, when the technologies were simpler and no one had ever heard of a CAT scan,
Yeah, right.
or a PET scan, or any of these kinds of things, when your bills were, $15 for the doctor's office visit and maybe, $5 for lab tests and an EKG.
Goodness
gracious.
Parking's that much now.
Exactly. The 20% was something that most people could handle.
Yeah.
Everybody thought this was fine. Now, as costs started to rise in the later 1960s and the early 1970s, that 20% starts to get bigger and bigger and bigger and starts to become more unaffordable, and the public goes to Congress and says, we need help. And Congress does what they're best at. Absolutely nothing. Private insurance steps in and creates what's known as the supplement or the Medigap. And this is a separate private policy that you can purchase.
This is your C+.
This is your C+.
Yeah.
That covers that 20% and that deductible from your Medicare A, so that it's not something you have to come up with out of your pocket. And while initially anybody could sell pretty much anything in that market, it's since been very tightly regulated, and now there are, I think, 14 different flavors, and you have to fit into one of those categories.
Right.
In terms of what benefits that you must offer and how it works and how it interdigitates with Medicare. So this is where we kind of are with the initial Medicare program and how it works and what people are now still think of as being, what Medicare is. And the 1970s are the go, 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 grow, grow, grow years. The federal dollars are flowing into the healthcare system, and Wall Street starts to take notice. They always take notice when money's sloshing around somewhere.
Well, of course.
And while healthcare had been not-for-profit, fairly small hospitals, and most doctors' offices are mom-and-pop private practices, and that Wall Street says, money to be made. And they start buying up the pieces of the healthcare system and corporatizing them and putting them together into bulk. And starting to run healthcare like they run every other industry, only instead of manufacturing widgets, it's manufacturing encounters or hospitalizations.
Yep.
And this is starting to really change how the healthcare system works. And the first huge shift in Medicare comes in 1983. Now, I entered the medical system in 1984 as my first year of medical school.
Yeah.
So I parallel all of this. And in 1983, how hospitals were reimbursed by Medicare prior were, if you had a Medicare patient and they were admitted, you just basically totted up everything that you spent on them, and you sent a bill to the computer in Baltimore and it spat back a check. There was no control on it in any way, shape, or form. And Congress said, this is a problem. We got to do something about this because, they just get bigger and bigger and bigger.
Right, sure.
Well, it's really very fun. When Medicare became law in 1965, Johnson gave this speech about, Medicare's budget for 1965 is $2 billion. Now, this is 1965 dollars, but it was $2 billion. And we have projected forward 25 years to 1990. And we see that with all of this going on, we know that in 1990, Medicare will cost us $8 billion. The actual cost for Medicare in 1990 was $88 billion.
Oh my
He was off by a
gosh.
factor of 11.
Wow.
It's now roughly $530 billion or
Wow.
something, because Medicare has more or less gone up by about, I think it's 12% per annum, since its inception. And, if we could find an investment vehicle with a 12% rate of return,
Oh.
yeah, we would be putting every penny we could find under the couch cushions into it.
Absolutely.
Because that means it doubles roughly every 6 or 7 years.
Yeah.
And so that's what Medicare has been doing because of changes in technology, changes in how healthcare works, changes in population and demographics.
And what
all adds up.
healthcare has been doing,
Yeah.
like the expenditure for healthcare and
Yeah.
the cost of healthcare has just gone up.
Yeah. But basically the reason why none of us has higher salaries is that all the money that would have gone into salary raises over the last 40 years has all gone into higher health insurance premiums.
Yeah. Ugh.
So in 1983, Congress turned to the work of a guy named Alan Entherman, who was a health economist at Stanford, and he had invented what is known as the DRG, the Diagnosis Related Group. And the DRG basically says, we can take all of disease that is worthy of hospitalization and we can put it in a nice, neat little pigeonhole. Mm-hmm. And there are, I think, 753 pigeonholes at this point or something. Mm-hmm. And rather than paying you what you think you're old, we were going to pay you a fixed dollar figure depending on what pigeonhole this particular inpatient fits. Mm-hmm. Now, there's all sorts of things that change the dollar reimbursement, such as whether it's urban or rural or underserved populations, blah, 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 blah.
Right.
But there's still a fixed check that comes with every Medicare admission. That's just the first of the major reforms that happened, and everybody said, oh, hooray, problem solved. No. Because what happened? I mean, hospitals are not stupid, not run by stupid people. They learned how to code.
Yep.
They learned how to figure out how to put people in the highest possible reimbursing DRG.
That's right. We still do that.
Yep. Anybody who's a clinician, anytime the person with the power hair and the clipboard is chasing you down the hall saying, you sure they don't have CHF? That's what they're doing, is they're trying to bump up the DRG in some way or shape or form. So that was kind of, the first change. The second change happens in 1987. And at this point, the wars over healthcare in this country go way, way back. This has been happening for a long time. Everyone at this point is yelling and screaming about catastrophic care and catastrophic expenditures. Because it's become realized that actually more people are going broke from medical expenses who are Medicare recipients than were prior to the existence of Medicare.
Oh my gosh. Yikes.
Yeah, and it's because Medicare, with its very narrow focus in that, there's a lot that just isn't paid for. Because if it can't be defined in acute care terms, Medicare's not interested. I mean, you see this a lot with dementia care, for instance. What does somebody with mild to moderate dementia need? They need a mom, someone to make sure they eat their sandwich, and if it's too quiet in the next room, what's going on, and don't play in the road, and you didn't take your medicine. That's what they need. Medicare don't pay for mom.
I know. Oh, I know.
But that's the treatment.
Yeah, that's right. That's right.
And so there's just lots and lots of things, incontinence products, you name it.
Yeah,
and they're just
so
not
many things.
paid for.
Right.
So Congress has the bright idea of making Medicare a stop-loss program, meaning that Medicare will, if you are a catastrophic beneficiary, if you spend more, I think it was like $2,500 in a year on your health care, Medicare would step in at the $2,500 and pay for everything else that year. So nobody should be going broke if they're a Medicare recipient.
That's for the donut hole. Is that where the
No,
donut
this
hole?
is that conflator.
No? Okay.
All right. This is, and Congress passes it with great fanfare that this is going to be, the solution to everything. You're not familiar with it because Congress repealed it in 1988 prior to it going into effect. And what's important about this is why. Congress knew that additional funds would have to go into Medicare revenues in order to be able to fund the small percentage of people who would need catastrophic benefits in any given year. And so they did it by placing additional tax burdens solely on Medicare beneficiaries. The elder lobby went ballistic. Not on my back alone, society-wide. You just can't be.
Right.
And this is where the elder lobby and that flexed their muscles politically for the first time. And this was pre-9/11. So, I mean, there were little old ladies running up and down the halls of Congress with their umbrellas chasing Congress people. There's like video footage of elderly people trying to overturn Dan Rostachowski's car in Dealey Plaza with him in it. And Congress said, oh my God, these people vote. And, Medicare, we cannot, do anything that will upset older people around Medicare because, we won't be able to keep your jobs if they do this. And it's kind of why Medicare became this untouchable third rail in a lot of ways politically. But they basically quietly repealed it and say, yeah, okay, we'll fix this, we'll make it society-wide. And they repealed it and just never came back to it.
Oh my goodness.
So that's 1988. Next major thing that happens is in 1993, and it's not Medicare specific, but by this time, there is a whole lot of yelling and screaming about, the costs of health care and the system not working right and corporatization and that. This is 30 years ago. And there was a surprise upset in the 1992 elections with Bill Clinton being elected after Ross Perot siphoned off enough of the Bush vote to allow him to get in. And he arrived in D.C., and one of the first things he announced is, I'm going to fix healthcare. Okay. And do you remember how he decided to do that? No. He put his wife in charge.
Oh, hey.
And Hillary is very smart and very astute. And she gathered all of the best minds that she could find in terms of health policy and economics, and had a whole series of closed-door meetings in D.C. for months, etc. And then came out with a plan for kind of reorganizing the American healthcare system, which is pretty good. But apparently, she never watched Schoolhouse Rock. How does a bill become law?
No.
Does it originate with the First Lady?
No.
It originates in Congress. And who had been shut out of all of the closed-door meetings?
No.
So she delivered this, this whole plan to Congress saying, here it is. And they said, we had nothing to do with this. Bye.
Oh, gosh.
Never came up for a vote or anything.
Oh.
But it basically began the Hillary hate that continues to this day. Bill never touched health care again in his 2 terms. After that particular experience, both he and Hillary felt they had been very badly burned.
Sure.
Okay. So now we move on. We're through the Clinton years, and we're into Bush 2. And Bush 2 is, at this point, we're all yelling and screaming about the fact that Medicare does not have a drug benefit. Why does Medicare not have a drug benefit? Well, it does. It always did. It paid for your discharge prescriptions for the hospital.
Yeah, acute care.
And it paid for drugs administered in the hospital or in the doctor's office.
Sure.
But what does taking a pill at home every day for years on end have to do with getting over your acute illness? Nothing. So that was never considered to be a necessary part of Medicare. And at the time, the pharmacopoeia is much smaller and much cheaper than it is now.
For sure.
So, nobody had ever thought about it, as, pharmaceutical research increased and we got better and better at treating a whole lot of things. And, consolidation in the pharmacy industry and rising in prices and all the rest of this, by 2004, we have this, oh my God, we've got a crisis. And under Bush 2, they passed the MMA, the Medicare Modernization Act. And the Medicare Modernization Act put in place what is sometimes referred to as Medicare D, which is the drug benefit. This is where the donut hole comes from. In that Bush said, I need this bill, but I refuse to sign a bill in which the CBO scores as costing more, and I don't remember what the dollar figure was, than X amount over the next decade. So you got to get it to me with that CBO score under that. And the only way they could figure out to do that was to put the donut hole in.
Really? How wild. Because the donut hole was always, like, to me, I was just like, someone randomly made that up.
No, that's why it exists.
Okay. It doesn't exist anymore, right?
As of, like, this year. Kind of does. But the other major thing that the Medicare Modernization Act put in is it codified a Medicare HMO, which had been experimented with for a number of years under Medicare Advantage. And Medicare Advantage basically says that if you so choose, you can purchase your Medicare not from the federal government in traditional Medicare form, but rather from a private insurer. And that private insurer must provide all of the benefits traditional Medicare does. And it has to provide some other little bells and whistles, to make it attractive. And it becomes convenient because your A and your B and your D can all come in one nice package, wrapped up with a bow, so you don't have to really think about all of that.
Yeah, and that's your Blue Advantage and your Humana, your
You
United
got
Healthcare, Medicare, and all of those plans.
These are all private insurance, masquerading as Medicare. How it works is that the insurance company tells Medicare, CMS, who they have enrolled in their plan, and also, how costly it is to them to take care of them based on how sick these individuals are, which is what the Medicare wellness thing is all about.
Yeah, capturing information to
boost that up. It has nothing to do with the wellness of the individual.
No, it doesn't, actually. I'm sorry to drop that on everybody, but...
So the federal government then gives a fixed dollar figure, it's modified by all these things, to the insurance company. Now, the insurance company has a fairly significant overhead. Traditional Medicare has roughly a 2% overhead. It's so huge that, 98% of the dollars in Medicare actually flow out to benefits. That 2 or 3% held back is still billions and billions and allows Medicare to run itself. In the private health world, you've got about a 25% overhead. Because you got to pay your stockholders and you got to run the company. And the companies are much smaller in general. And we won't even go into CEO salaries and things like that. So they have to be able to provide the same benefits that Medicare does, but on about 3/4 of the money. How do you do that? And the way they do it is that Medicare says you can put contracts in place and, make a network. And then confine your beneficiaries to that network of contracts, that provide value to you. Under traditional Medicare, I can go to anybody who accepts Medicare anywhere in the country. If I want to go to the Mayo Clinic, fine. If I want to go to the Honolulu something or other, fine. Medicare doesn't care. But under Medicare Advantage, I am signing away that right to go anywhere, and I'm saying I am agreeing for these little extra things you give me and for the convenience you give me, that I will only use these providers that are part of the network that you have created. And that network should include anything I might need. But because those contracts are often somewhat skimpy, that home health agency may not be getting all that much for you. You may not necessarily be getting quite as much as you might.
Yep, that's true.
And the Medicare Advantage business has grown like crazy, mainly because they've got very, very good at advertising and direct advertising to a consumer group who cannot see through the ads.
Yeah, people do not understand what they're actually signing up for, and people get into those plans. And I do think those plans can be good for certain people.
For certain people, I think they are absolutely fine.
Yeah, but people get sucked in with the dental benefits and when it may not be actually what was best for them. So. Hard.
Yeah, and once you are in, you can shift every year, but you can only shift during the open enrollment period, which is usually October and November.
Yeah, it's confusing. People are very confused by it. Some people have Medicare Advantage and they don't realize it. We know that. They think they're like, I have Medicare.
Yeah, they have no idea how they're classified.
Yeah.
Or what they signed up for. But believe me, the system knows.
Yeah. Oh, the system knows because we access the system and it tells us.
Yeah. All right. So that was 2004. The next big, huge battle is, of course, in 2010-11, and that's the Patient Protection and Affordable Care Act, Obamacare. Now, Obamacare, for the most part, doesn't do much to Medicare because Congress knows we don't want to do anything.
Don't want our cars turned over.
Exactly. So Medicare was left out of it for the most part, but a couple of things did happen. The first was that Medicare was defined under law for the first time as being health insurance. Before that, it was Medicare.
Yeah.
But legally, it was Medicare, but not health insurance. By defining it legally as health insurance for the first time, any law applying to health insurance then applied to Medicare.
Oh.
Which is why all of a sudden preventive tests and that which had not been available under Medicare all of a sudden became available.
Oh, wow. So
there were carve-outs for specific tests and that. Like mammography, there had been a specific carve-out to get Medicare to pay for it. But general preventive care was not part of Medicare at all until PPACA. Because what does that have to do with you taking over your acute illness?
Right. So you're talking CT for lung cancer screening and colonoscopies and things like that. Yeah. Medicare wasn't paying for until...
And now, because it's health insurance, it is required to pay for anything that, health insurance is legally required to pay for. So that was one significant change. The second significant change was that Medicare was, for the first time, looked at as needing to take care of chronic illness. Pre-ACA, if you were running a health system in a hospital, your job in terms of your Medicare patients was to basically brand them so they would keep coming back to your hospital. Got CHF? Oh, you got an exacerbation? Come back here. Come back here. Come back here. Oh, you came in 6 times last year.
Awesome.
Oh, awesome. We got 6 DRGs.
Yeah.
And for the first time, carrots and sticks were buried in the legislation that basically amounted to, if you keep admitting somebody for the same damn diagnosis, maybe you're not actually doing your job to make them better.
Right, exactly. We're not going to pay you for it.
Yeah. And so those carrots and sticks were phased in over the next few years. They didn't all kind of fall into place at once. And the one that really had some impact on me came about in 2014, when the people coming back for the same DRG, kicked in.
Yep.
And For the very first time, and I had been trying to get, UAB for us to do house calls since the late 90s.
Mm-hmm.
And they had no interest because there was no money in it.
Mm-hmm.
They became very interested for the very first time at going, oh, we have these people that keep coming back. We have no clue what goes on in their lives. We better start figuring this out.
Right. Because there's so much more behind the scenes there.
Yeah. And so for the very first time, UAB got interested in building community relationships and putting together a house call program, things like that. Never been interested in doing anything like that before. And those things are still part of the system in general, and the system in general has gotten much better at, understanding in the elderly kind of what goes on in the world and
what
how
drives
complicated
rehospitalizations, right?
Yeah, and that's only been in the last 10 years.
I think we still have a lot to learn.
Oh yeah, it's hardly perfect, but it's certainly better than it was.
Yeah.
And of course, the next thing that happens is the pandemic, and that just kind of drives everything crazy. Now, the biggest issue with the pandemic is that roughly 20% of the people who were employed in direct clinical health care in 2019 are no longer employed in direct clinical health care.
Yeah.
And in terms of practical purposes for the Medicare population, there is not an entity out there involved in providing senior health services of any stripe that is appropriately staffed. They can't get the people.
Yeah.
And so the delays in care, the inability to access specialists, understaffing in nursing homes, having to cut way back on what a home health agency or a hospice can do. All of this, of course, is also driven far more consolidation in the industries, more corporate control trying to fix all of this, but it's not really fixable in those ways.
Yeah.
And now we're just kind of coming out of that. And then in 2025, we have a new administration where the Center for Medicare and Medicaid Services is now run by Dr. Oz.
Yeah.
And the Department of Health and Human Services is run by Robert F. Kennedy Jr., neither of whom are necessarily devoted to any kind of scientific principles in medicine.
Yeah.
And just exactly where and how that's going to play out is anybody's guess.
That's right. Yeah.
All I can say at this point is I am now 63 years old, is I am reaching the end of my life. I was professional life.
Right.
I was built for a very different health system than the one we are currently creating. And I don't fit anymore.
Yeah.
So I am planning on working until I am eligible for Medicare, and then I am going to phase myself out because it's a new generation that is brought up and instructed and understands new ways is going to have to solve these problems.
Yeah. I on 65.
21 months. But who's counting?
Oh, I'm not sure how many more months I have, but...
Well, and that is my long talk on Medicare and why it is the way it is.
Well, I mean, it was certainly enlightening. I mean, so much of that back history was so unaware of. So...
Well, I figured out years ago when attempting to teach, medical students and residents about, why is Medicare the way it is? Because they're always going, what?
Yeah.
The only way I could figure out to make it make sense
Yeah.
was to put it together in that way and to show that it's all about smart people solving their problems.
Yeah, that's right. Right. Yeah.
And it has to be, the problems change. And you have to change the solutions as the problems change, but we're not very good at that.
We have not been good at that. Not at all. Yeah. When you know better, you do better, and that's all we can try to do.
All right. I'm sure we'll split this into a couple of different parts. I'll let the tech whizzes figure that one out.
Sounds good. Well, thank you for joining us today.
It's been my pleasure.
Yeah. All right, everybody. Thanks for joining us. Be sure to like, subscribe, share. You can find us, of course, on YouTube, Spotify, and Apple. And thanks so much for joining us. We're always happy to have you and look forward to you next time.